I'm Dr. David Robertson, and today we're going to be talking about allergic disease. So this is a talk that's designed for medical residents, and the idea is to give a general overview um, of the world of allergy, which is generally underrepresented in medical training. So I'm a partner at a practice in Western New England, Western Massachusetts, called Allergy and Allergy Associates of New England. I have no relevant financial conflicts of interest to this talk, and I will not be discussing off-label use of medications. So the goals of the talk are to recall, kind of differentiate the different types of hypersensitivity reactions, which is really what we're talking about when we say someone is allergic to something, to become familiar with the different modes of allergy testing, generally kind of talk about the epidemiologic burden of allergies in the population, in the U.S. population, and then to kind of understand where we're at in allergy immunotherapy. So first of all, what does it mean to be allergic? So there are lots of different ways that foreign substances can affect your body, and some of them are not good. So these, I think, can generally be classified as adverse effects, but not all adverse effects are allergies. So in terms of food, in 2007 they did a study and they found that somewhere between 3 to up to 35% of the US population was avoiding specific foods due to perceived um, issues with specific foods, with about 20 to 30% of the population actually restricting their diets on a regular basis because of this. Now, the actual rate of food allergy in the adult population is only about 3 to 4%, and it's about 4 to 8% in kids. So there are many more people that perceive an issue with food than are actually allergic to it. So what are some of the other ways that foods or other things like medications um, can affect you? Well, one of them would be metabolic, right? So the most common example here would be lactose intolerance. So we see a lot of people that come in and they say, when I drink milk, I kind of get an upset stomach and diarrhea and bloated. But if I drink lactate milk, I don't seem to have that problem. That is a real, well-defined problem, and what causes lactose intolerance is an inability to break down the sugar in milk. So there's three components of milk. There's milk fat, milk sugar, and milk protein. Milk fat is the difference between cream and skim milk. Milk protein, and proteins in general are what people become allergic to. And then there's milk sugar, and milk sugar, right, is lactose, which is glucose and galactose stuck together. They're a dimer. And what's supposed to happen if you can digest milk is that in your stomach, your body makes lactase, the enzyme that breaks these things apart, and it breaks it down into its constituent parts that can be absorbed in the intestine. If you don't make enough lactase, that doesn't happen, and the lactose moves down into your lower intestine where the bacteria that live there can digest it, and it's like a party for them. You're pouring a bunch of sugar on bacteria, they reproduce, they make a bunch of metabolic byproducts that produce gas, that make you feel bad, and can cause diarrhea. It's a real thing. It will not show up on an allergy test. Other metabolic ways that foods can affect you is if you have too much caffeine, it can make you jittery. Sugar can affect a diabetic, or turkey can make you sleepy if you eat too much of it. None of those are allergies. Toxic effects. The most common one, probably alcohol, right? We poison ourselves on a fairly regular basis in America by drinking alcohol. Not good for your body. It can cause altered states of mind, it can cause flushing, and other kind of feelings. Some people have alcohol dehydrogenase deficiency. Again, none of these are allergies. Food poisoning is another one. Another interesting one is scromboid, which happens from when you eat fish that has not been properly handled. And what happens sometimes is there are dinoflagellates that convert the histidine that naturally occurs in fish into histamine, and when you eat it, it actually can produce a pseudo-allergic reaction where you have generalized itching and flushing and redness. It's not an allergy, you're just eating a bunch of histamine. Generally, this happens to everybody that eats the food because it's a non-specific, not specific to the patient. So taking a good history there can help sort that out. There are idiotypical reactions that we just don't understand. When I was a fellow, I remember I had this engineering student who came in, and she was very organized, and she had a lot of somatic complaints related to eating. Most of them were brain fog or just general fatigue, but there were two that stick out in my mind, and I'll always remember this. One was blueberries. Every time she ate blueberries, made her extremely angry. And when she ate onions or bell peppers, it caused a sense of hopelessness or depression. And she wanted to be allergy tested for these things. Well, you know, these reactions are not typical for an allergic process, and more than that, they're not typical for a process that would lead to anaphylaxis, but she's already failed the only test that I care about, right? She tells me every time she eats blueberries, she gets angry. If that's the case, if I do an allergy test and it's positive, I'm going to tell her don't eat blueberries because they make you angry. And if we do an allergy test and it's negative, I'm going to say don't eat blueberries because they make you angry. So the test really wouldn't change anything that I do. But those are certainly idiotypical. There are other people that don't have celiac disease who aren't allergic to gluten who also feel that they feel better when they don't eat gluten. Again, this isn't something that is well understood, but it can be a real effect. So when we're talking about allergy, what we're really talking about, right, are hypersensitivity reactions. So these are immune reactions, and the term hypersensitivity is a little bit of a misnomer. It's not that they're excessive, it's that they're actually somewhat inappropriate. Because with hypersensitivity reactions, what's happened is your immune system is overreacting, or they're recognizing foreign proteins that are not dangerous as a threat and are overreacting to it in well-defined specific ways. So you may remember from your 2 weeks of immunology that there's this Gell-Coombs classification, right, of hypersensitivity reactions. So there's 4 main types of hypersensitivity reactions. Type 1 are immediate, and that's typically what we're talking about when people talk about allergies. These cause hives, trouble breathing, seasonal allergies, can exacerbate asthma. Type 4 hypersensitivity is delayed type hypersensitivity, and it can play a role in some allergic diseases, most prominently allergic contact dermatitis. And we're going to talk about those two in more detail later on in the talk. But it's reasonable to kind of just review type 2 and type 3 hypersensitivity reactions, which very rarely play a role in allergic disease. But they do play a role in other disease states. So type 2 hypersensitivity reactions are antibody-dependent cell-mediated cytotoxicity. That's the classic type 2 hypersensitivity. So what happens here is your body makes antibodies, typically IgG antibodies, that bind to and coat a foreign cell, which generally is a good thing because this is how your body kind of opsonizes and gets rid of microbes, which is what you're seeing here in the diagram. When this is not a good thing is when your body's doing this with cells that you actually want. So type 2 hypersensitivity has classically been things like the cytopenias that you see, like HIT, or so heparin-induced thrombocytopenia, or ITP, idiopathic thrombocytopenic purpura. In HIT specifically, what happens is there's something called platelet factor 4, which cross-reacts with a component of heparin. And so when your body gets exposed to heparin, for some people, they recognize the heparin as a foreign thing, and that antibody that they make then also binds to platelet factor 4, leading to destruction of your platelets and causing HIT. More recently, the definition of type 2 hypersensitivity has been expanded to be type 2A and type 2B. So type 2B, there's another inappropriate antibody that's made, but it's actually receptor binding. So rather than leading to opsonization and destruction of the cells, it actually binds to activating receptors and causes things like autoimmune disease. So this would be Graves' disease or myasthenia gravis. Type 3 hypersensitivity is all about immune complex deposition. So, so in our talk on innate immunity, we talked about complement. And complement is a part of the innate immune system. It's a very old and kind of relatively simple part of the immune system recognizes molecular patterns. There's a few different things that can activate it. One is lipopolysaccharide, which comes from bacteria. Another is mannose binding lectin, which recognizes fungal antigens. And then the last one are actually your own antibodies. So in type 3 hypersensitivity, what happens is, again, your body has recognized things that are not dangerous, often self-proteins, as a foreign thing, has made an antibody against it, and then complement binds to it. And these complexes of antibodies and complement clump together and end up depositing in small capillary beds. So the solubility of immune complexes is dependent on the ratio between the antibody and the antigen. So when they are matched, when you have a 1-to-1 ratio, they're at their highest. And so that's when solubility is the best, and these things are going to stay a solution in blood. When you have, and just to be clear, it's not a bad thing to have immune complexes. This is how your body clears bacteria, or one of the ways that your body clears bacteria or other foreign proteins from your body. But when you have a disruption in this ratio, when you either have way too much antigen or way too much antibody, then these immune complexes fall out of solution. And so this is the fundamental mechanism for lupus, right? Because in lupus or other autoimmune diseases, the antigen is you, and you essentially have an infinite amount of antigen. And so you're way over on the right side of the graph. And so what happens is these immune complexes deposit in tiny capillary beds. So if you think about lupus and the areas that get affected, it's the capillaries of the joint space, the eyes, the bone marrow, potentially cardiac tissue, renal tissue. So this is, when I first, I never had a good handle on lupus until I actually was an allergy immunology fellow, because it just seems so arbitrary and random where these things would deposit or the tissues that were affected. But it's really basically immunologic sand getting stuck in small capillary beds that causes lupus. Other autoimmune diseases that are similar or are also type 3 hypersensitivity disease, type 3 hypersensitivity diseases include rheumatoid arthritis, and then from kind of foreign antigens, post-strep glomerulonephritis or serum sickness. Serum sickness, I think, deserves a special consideration because we see a lot of rashes that are sometimes associated with antibiotics. So the classic complex of serum sickness is the triumvirate, the three symptoms of rash, fever, and joint pain. So if it's a drug rash that occurs significantly after exposure, so classically it's 7 to 14 days. However, with repeat exposure, it can be quicker than this. But if there's fever and joint pain associated with the rash, that should be a red flag for serum sickness. Again, this is caused generally by foreign proteins. So classically, the reason it's called serum sickness is from the bad old days of medicine when we actually used to use things like horse serum and injected people with it to protect them and as an early kind of vaccination or after exposure. It can happen with monoclonal antibodies, which we're using more and more. Very rarely can be associated with insect stings, but more commonly now are antibiotics. So penicillins, cefaclor, Bactrim are the most commonly associated antibiotics. And the rash can be kind of, doesn't have one specific morphology. So this is a picture of a baby with serum sickness, but here's another picture of an arm, and it's a different kind of rash. So it's really about having a high index of suspicion. Unfortunately, for immune complex disease and serum sickness, there's not really great testing. Having a high index of suspicion is really the key in taking a good history. Serum, if you got a serum complement level, serum C3 or C4, you'd expect these to be consumed in serum sickness. And if they're low, that certainly supports the disease, but it's not diagnostic. The treatment for this is to remove and avoid. There is, if somebody has a remote history that suggests serum sickness, there's no testing for this, and with re-exposure, if they have persistent immune memory, they can have more severe symptoms. So in general, if you've had serum sickness caused by a drug, you should essentially avoid it for life. If you have somebody with acute serum sickness, generally the treatment is a long steroid taper. So again, if the history is that the rash resolved in a day or two, that's, well, again, not suggestive of serum sickness. All right, so moving on to type 4 hypersensitivity. So this is delayed type hypersensitivity. Going back to our immunology talk, this is caused by memory T cells. So these are CD3 positive T cells, which all T cells are CD3 positive. And then there's CD8 T cells, which are your cytotoxic T lymphocytes. So what happens in this condition, or these conditions, is that you've made memory T cells that have recognized something as a foreign body, and they're hanging out in your lymph nodes. And they're memory T cells, and they're just waiting to be reactivated. And what happens is then the classic one is contact dermatitis. And so with contact dermatitis, you are exposed to something through the skin, and sampling cells, usually dendritic cells, pick this stuff up, and then they move and carry the antigen in question to the lymph nodes, where they show it to the memory T cells, which then reactivate. And there is something called CCR7, which is expressed on the surface of these cells, and it's almost like molecular Velcro. And it binds to something called CCL21 on the surface of the veins in the lymph node. And when a memory T cell is exposed to a dendritic cell and reactivated, it just stops making CCR7, and that Velcro goes away, and it just kind of floats out, and then floats down or travels down a kind of cytokine gradient to home back to the area of exposure. And this can be pretty impressive, right? So the classic T-cell mediated hypersensitivity is poison ivy. And so this is pretty significant, right? So this is a blistering rash. Generally, so here's the deal with poison ivy. There's no testing for it, but it is a hypersensitivity reaction. So the oil, urshadiol, in poison ivy is a skin irritant, but not everybody, quote, gets poison ivy. People who get poison ivy have seen it once and have developed a delayed type hypersensitivity to it. So the general history is, you're out in the yard and maybe you're a little bit itchy on day one. Everybody might be a little bit itchy on day one because this stuff is a skin irritant. But people who have a hypersensitivity to it on day, the next day or maybe even 48 hours later, develop this kind of impressive dermatitis. Topical steroids are the treatment of choice. If you need to, you can treat it with systemic steroids. So it turns out that there are a number of allergic diseases that are associated with delayed type hypersensitivity. So contact dermatitis for sure. Drug rashes. So there are non-serum sickness, non-IgE mediated drug rashes that can often be associated with type 4 hypersensitivity. These are not necessarily an absolute contraindication to using these medicines in the future. And again, the story is, I was on the medicine for a while. I got a rash. It lasted for a few weeks. It was itchy, but there was no blistering or skin breakdown. In that picture I showed here, you can get blistering associated with it. The reason that for a drug rash blistering is a contraindication is that it could be indicative of a more serious process like Stevens-Johnson syndrome or toxic epidermal necrolysis. Delayed type hypersensitivity can also play a role in eczema, eosinophilic esophagitis, and the allergic gastropathies. The classic allergic gastropathy is milk protein intolerance, but there's a broad spectrum which ranges from the mild, which would be milk protein intolerance, to the severe, which is FPIE, which is food protein-induced enterocolitis syndrome, which can be associated with very high volume diarrhea. In general, if somebody has milk protein intolerance, then we do allergy prick testing, which is a marker designed for IgE-mediated allergy. It's not going to show up, but sometimes we can find evidence of it when we look for delayed type hypersensitivity. So how do we do that? How do you test for delayed type hypersensitivity? Well, it turns out most people in this room have probably had a test for delayed type hypersensitivity about once a year. And that would be your PPD, right? So with your PPD, you go in and you have a bleb placed with purified tuberculin protein, and then classically you come back 24 to 48 hours later to have it read. And what you're looking for is signs of induration or swelling, right? And so a positive PPD looks like this. And so what's happened in that 24 to 48 hour period is those dendritic cells have picked that stuff up, carried it to your lymph nodes, and if you've been exposed to tuberculosis and you've formed immune memory against it, then those T cells have been reactivated. reproduced and then home to this area, and now you have a T cell mediated response on your arm. So we can use this same type of idea to look for delayed type hypersensitivity. However, if we're worried about an allergy to, say, nickel, which is the most common cause of allergic contact dermatitis, it seems like a bad idea to squirt nickel under your skin. Or if we're worried about milk protein intolerance, it's the same thing. It seems like a bad idea to squirt milk under your skin. Many things are not designed to be placed under the skin, but we can place them on the skin. And so this is patch testing. So patch testing, these are fin chambers, which are little metal discs with a cup on the inside, and you can load them with whatever the substance in question is, and you do the same thing. You keep them in contact with the skin for 24 to 48 hours. The downside with that is you can't get super sweaty and you can't get the area wet. So anything that would make a Band-Aid or a sticker fall off is prohibited while you're doing patch testing, which sometimes patients don't like. And it's slightly uncomfortable to have stickers on your back. But then the patches are placed, and 24 to 48 hours later, you can go up to 72 hours. They come back and you peel them off, and what you're looking for, again, is signs of induration or swelling. So that would be a positive patch test. So you can see there are actually 3 little indentations. There's one on the upper left, actually, sorry, 4 indentations. There are, in addition to the positive one on the upper left, one on the upper right, lower right, and maybe, I think there's one on the lower left, but it's kind of obscured by a little mark in the picture. But again, with just like a PPD, you're looking for the induration. So really you should be able to close your eyes and kind of rub your finger over the area and feel a positive patch test. And this can be useful if it's positive. The negative predictive value, especially in the context of food allergy, is fairly poor, only about 20% for milk specifically. So it's useful if it's positive. If it's negative, it doesn't necessarily exclude the disease, depending on what the substance in question is. All right, so finally, we're going to talk about type 1 hypersensitivity, which is really what people are talking about when they say, oh, I'm allergic to peanut butter, or I'm allergic to cats. This is what people are talking about. So in a second, we're going to talk about mast cells. Mast cells are the fundamental effector cells of IgE-mediated allergic disease. They're the end product. But the real problem in allergic disease is not mast cells. Everybody's got mast cells. Not everybody has allergies. The problem when you have IgE-mediated allergies are actually memory B cells. So how do you get these memory B cells? So when you're exposed to something for the first time, an antigen-presenting cell picks that stuff up and then presents it to a naive T cell. So you got your T cell receptor here, and when that happens, when the naive T cell sees a new foreign antigen for the first time, a few different things can happen. And it all kind of depends on the cytokine milieu, the different signals that the T cell is exposed to at that time of antigen presentation. So typically what you want to have happen, if you eat a cheeseburger, your body's going to be exposed to beef proteins and wheat proteins and milk proteins, and all of those are foreign proteins, but none of them are a threat to your immune system. So your body needs to have a mechanism for recognizing that things are foreign but not dangerous, and that mechanism is immune tolerance. And the T cells that kind of drive immune tolerance are T regulatory cells. So these are cells that either calm down an inflammatory response once it's an appropriate inflammatory response once it's happened. So if you get sick and you have a cold, you want your immune system to rev up and fight the cold, but once the threat is removed, T regulatory cells will tamp down that response. Or they can also help your body recognize proteins that are foreign but not dangerous. When there are other signals there, you can get allergies. And so the cytokines that generally predispose to development of Th2 cells, which are the T cells that drive allergic disease, are IL-4 and IL-5. Things that kind of predispose to developing allergies are an abnormal route of antigen presentation. So, for example, in eczema, sometimes kids have primary eczema caused by dry skin, and then the skin gets red and cracked and inflamed. and then you can get cutaneous sensitization where proteins get into the immune system through the skin, and then that can predispose to allergic disease. IV medications. So IV antibiotics are the most common cause of drug allergy. And again, this is an abnormal route of antigen presentation. Similarly, high dose and intermittency, and also being presented in the context of inflammation, all of which can happen with specifically the antibiotics again. So if you went and ate an entire bag of Reese's Pieces and didn't eat peanut butter again for 3 months, you would probably have an increased chance of developing allergy to peanut versus eating a small amount of peanut butter every day. So those are kind of the predisposing factors there. So once you have your Th2 cell, well, actually, I should say that you can have both T regulatory cells and Th2 cells, which both recognize the same thing, and they kind of are in conflict with each other. And so it's a signal to noise ratio. Which one has the strongest signal? And that's going to kind of determine which is the predominant effect in your body. So T regulatory cells make things like IL-10 and TGF-beta, which again kind of down-regulate and tamp down the immune response, including Th2 cells. So Th2 cells make a number of cytokines, and cytokines are signaling molecules, right? So you'll notice that there are a number of feedback loops here, right? So IL-5, if it's floating around and the naive T cell is exposed to that, that can predispose to making Th2 cells, and then Th2 cells make more IL-5, and IL-5 is the driving factor for your body to produce eosinophils. And there are now 2 medications, mepolizumab, which is called Nucala, and rezoluzumab, which is called Sincair, which are anti-IL-5 monoclonal antibodies that are designed to block eosinophil production. And these are now indicated for the treatment of allergic eosinophilic asthma. And they totally wipe out eosinophils. Other cytokines that Th2 cells make are IL-4 and IL-13. And IL-4 and IL-13, IL-4 specifically, again, you see a feedback loop here. IL-4 is around, it makes Th2 cells, and Th2 cells make IL-4. And this is one of the reasons that once you have one allergy, you're more likely to develop other allergies because you already have this population of T cells that are making these cytokines. And so when you get exposed to new antigens, you're more likely to become allergic to them. So IL-4 works on B cells, which we discussed in Immunology 101. So B cells are the cells in your body that make antibodies. And there's several different antibodies that your body can make. IgM is the first antibody your B cell makes when it recognizes something as a foreign protein, and then it class switches. And what that means is the tail end of it changes, and it changes the function of it. So when B cells are exposed to IL-4, they class switch from making IgM to IgE. IgE is the antibody that binds to the surface of mast cells, and then now you're allergic to something. So now you have IgE that recognizes something, whether it's cats or pollen or peanut butter or milk, as a foreign thing, and they're sitting on the surface of mast cells, which are distributed in your tissues. And when you get exposed to it, right away, the IgE is already made, and the mast cells are primed with these histamine-containing granules, and you get an allergic reaction. So the fundamental problem with allergy are the B cells, not the mast cells. So this is a diagram of a mast cell, right? So you've got this surface-bound IgE, which are the antibodies here. And inside you can see that there are these kind of red histaminic granules, right? And that green thing is supposed to be a foreign antigen that's going to come down and activate the mast cell. So finding a good video of mast cell activation on the internet was kind of difficult. Finding a bad video was relatively easy. So in this video, you're going to see this antigen comes down and it sends some kind of electric signal down, and then the mast cell explodes, histamine granules are released all over the place, and you're left with this nucleus floating in space. Well, that's actually not what happens. The mast cells don't explode, and the mast cell activation isn't caused by a single IgE molecule. What happens is you've got the surface-bound IgE, and it's IgE cross-linking. So what happens is when an antigen comes down, a single antigen will stick to 2 of those kind of arms that are sticking out, and it causes the intracellular tails of the IgE molecules to get close enough that they interact with each other and cause a phosphorylation cascade and activate the mast cell. When that happens, those histamine-containing granules are released, but the cell doesn't explode or die. And those granules contain a lot of chemicals, but the major chemical that we care about is histamine. So histamine makes things red, itchy, and swollen. So if this happens in your eyes, you get itchy, watery eyes. If it happens in your nose, you get sneezy or congested. If it happens in your lungs, it can make asthma worse. If it happens in your skin, you can get hives. And if it happens systemically, that's anaphylaxis. There's also a histamine receptor on the surface of the mast cell. So this is a crucial concept. Allergic reactions are chain reactions. So one mast cell, in addition to releasing histamine and causing symptoms in tissue potentially, also goes back and recruits other mast cells. So the longer you wait to treat an allergic reaction, the worse it's going to be and the more it's going to progress. And this is where antihistamines work. So antihistamines do not soak up histamine. They're not sponges. What they do is they block the histamine receptor in an inactive conformation. So functionally, they're competitive inhibitors. So if you're having allergy symptoms on a regular basis, it would be better to have an H1 antihistamine. So the H1 antihistamines include everything you think of as an antihistamine: Benadryl, Claritin, Zyrtec, Allegra, things like that, sitting there blocking that receptor. So if a mast cell gets activated by IgE or by another process, because IgE is not the only thing that can cause mast cell activation, it's better to have an antihistamine sitting there blocking the activation of further mast cells. There are four histamine receptors: H1, 2, 3, and 4, very cleverly named. H2 blockers, things like Zantac, typically these occur in the stomach and play a role in the production of mucus. So if you block histamine, you have increased, so if you block an H2 receptor, you have increased mucus production in the stomach, which helps fight dyspepsia. H2 blockers have a very limited role. The evidence for them is very weak for the treatment of allergic disease. It's very hard to have an allergic reaction or to have hives and walk out of an emergency room without being given an H2 blocker, but the evidence for them is weak. So one other thing to kind of think about, like I said, the mast cells don't actually explode, they get activated. And when they get activated, their intracellular machinery gets turned on and they make late products. So they start synthesizing things. The major molecules that they make are leukotrienes and prostaglandins. So leukotrienes, these are the cis leukotrienes, and this is where things like Singulair work. So Singulair is a leukotriene receptor antagonist. So it works in a similar way to antihistamines, but it blocks leukotrienes. The original name for leukotrienes were the late-acting substance of anaphylaxis. So these are the things that drive biphasic allergic reactions. So there's this thing where you can have a significant allergic reaction, and then 6 to 8 hours later, or sometimes even a little bit longer than that, you can have a second reaction. The biphasic reaction, the secondary reaction, is universally, I always hate to say 100% in medicine, but to the best of my knowledge, there's never been a documented case of a biphasic reaction where the secondary reaction was more severe than the primary reaction. And this is driven by these synthesized products. So when you treat someone with an allergic reaction with steroids, steroids have no role in blocking or stopping the initial reaction. The initial reaction is caused by preformed mediators, not synthesized products. When you give somebody steroids, right, if you remember, corticosteroids work by blocking protein synthesis at the nuclear level. So they shut down that intracytoplasmic machinery that lets these things be produced 6 to 8 hours later. So when you treat somebody with steroids, you're trying to block any type of biphasic reaction. Other things to consider: the Fc epsilon receptor, that's the IgE receptor, is one thing that can cause mast cell activation, but there are complement receptors, there's stretch receptors. Interestingly, there's even a codeine receptor on the surface of mast cells. So when people get kind of itchy and hivey after taking narcotics, specifically codeine, but any narcotic, that is non-specific mast cell activation. complement. Complement is a part of the immune system. So anything that causes systemic inflammation can cause nonspecific mast cell activation. So, 10 times a week I see a kid who got a cold and then they got an ear infection and they got put on amoxicillin. 5 days into the amoxicillin, they broke out in hives. Are they allergic to amoxicillin? Maybe, but 95% of the time, probably higher than that, when they come into the office and we do allergy testing to amoxicillin, it's negative, and then we do an oral challenge to amoxicillin, and they tolerate it with no issue. They're not allergic to amoxicillin. The reason they broke out in hives is because they were sick in the first place. And the stretch receptors, there are physical urticarias like dermatographism, where you just scratch your skin and you get a hive in that area. That's non-specific mast cell activation. So how do you know, how do you figure out what's the best testing for IgE-mediated allergy? Actually taking a good history is, honestly, I would say that if I take a good history, 95% of the time, I have a good feeling for, is this an allergy problem or not an allergy problem? What is causing it? If people tell me that, every year around Mother's Day, they get itchy, sneezy, watery eyes, I'm going to say you're allergic to birch tree pollen. And then we do the allergy testing to confirm it. And that's what allergy testing is for. It's to confirm your suspicion. It should never be done as a screening test for disease, because you can get false positives, which then opens up a whole new can of worms. So what is allergy testing? This is what it looks like. So the idea is you want to introduce a small amount of the antigen in question under the skin to reach these mast cells, which are bound in tissue, and to see if you can activate specific mast cells that are sensitized to these substances. So there's always going to be a positive and a negative control. The positive control is to make sure that the skin is reacting appropriately. So if somebody took Benadryl or Claritin or Zyrtec within a few days of allergy testing, the positive control will be negative, and you'll say, oh, I can't really interpret other negative tests. In the bad old days of allergy, interestingly, we actually used to use codeine as the positive control, but that was before the days of controlled substance regulation, and we don't want to really have bottles of codeine floating around the office anymore. So we use histamine. There's also going to be a negative control, because everybody has different level of skin sensitivity, and some people will actually have dermatographism, just get a hive from scratching the skin. So then we compare the positive and negative tests to the actual skin testing. In the bad old days of allergy, they actually used to use needles, sometimes like a sewing needle, and now we use these kind of plastic toothpick things that there are more fun ways to spend an afternoon, but they're not terrible. So you can see here, this baby has had allergy testing and has some positive results. The one on the upper left-hand side looks kind of positive, and the one at the lower left-hand side also looks kind of positive. And then there's some other ones that are kind of like slightly red, and what does that mean? So how do you interpret this testing? We're going to talk about that in just a second. Occasionally, specifically for environmental allergens, we'll do a second round of testing, which is intradermal testing. So it's actually the exact same technique as a PPD. So you're placing a little bit of this allergen under the skin with a syringe. So these are 25 gauge like insulin syringes. And the idea here is that we want to make sure we're not missing anything. And so we're looking for mast cells that are maybe at a just slightly deeper level surface of the skin. We certainly find positives to it. It's done fairly routinely across the country. There are a few allergists who feel that you get too many false positives when you do this, and so they don't do it, but most allergists do when they're looking for environmental allergies. It's never done for food allergies because of the risk of false positives. So how do you interpret skin testing? Well, when you have mast cell activation, you should have two things. You should have a hive. And a hive is characterized by a wheal, which is the raised area, and the flare, which is the area of redness. So the wheal is the bump, and the flare is the redness. And you measure across the widest diameter here. And you compare this not to the histamine, but it's compared to the saline control. So if somebody gets a big bump from the saline control, interpreting it all has to do with the millimeters of how big it is in millimeters versus the saline control. And so you see this kind of scale often used 1+, 2+, 3+, 4+, but it's certainly not standardized. And occasionally I have somebody that comes from another allergy practice and they have 5+ and 10+, and it's not really standardized. So in the context of environmental allergy, we really are carrying, it's more of a binary question. Is it positive or is it negative? Are you allergic to dogs or are you not allergic to dogs? Interestingly, the size of the testing does not necessarily correlate with the severity of the allergy. So if you have a bigger bump to dogs and to cats, it doesn't necessarily mean that you're going to have a more severe reaction when you're exposed to dogs than cats. It's all about the likelihood of reaction. So if you looking at old data, they looked at whether an allergist would do skin testing and say, yeah, this looks positive, this looks negative. And just based on was it positive at all or was it negative, they looked at the sensitivity and specificity of testing to common food allergens. So HE is hen's egg, CM is cow's milk, wheat, and soy. And you can see if you look at hen's egg, pretty sensitive, 93% sensitive, but not very specific. So you got a lot of false positives there. If you look all the way over to soy, not particularly sensitive, so it wasn't good at really picking it up, but it was specific if it was positive. So wow, this really isn't very good testing. So the question is there a way to increase the predictive value of allergy testing to these? And there is. We use math and statistics. So what they've done are called receiver operator curves. And so receiver operator curves are a way of looking at the size, making it more of a quantitative test. And what it is you look at they've looked at the size of the wheel, the size of the bump versus the saline control, and have looked at where is the 95% cutoff for the positive predictive value. Above what size will you have a greater than 95% chance that this is a real food allergy? And interestingly, for most foods, it ends up being about 7 or 8 millimeters. So the size of the wheel, the size of the bump, should be 7 or 8 millimeters larger than the saline control. And if that's the case, it's greater than 95% chance that you're actually truly allergic to these things. So sometimes we can't do skin testing, or we want to look at things in a different way. Reasons we couldn't do skin testing is if patients have just terribly disrupted skin, like in the case of eczema, or if they're not able to stop their antihistamines, or if they need to be on high-dose steroids for a long time, all of which can interfere with allergy testing. So sometimes we want to do blood tests to look at this. And so these, so the classic blood test is RAST testing. And it's still, testing today is still called RAST testing, although RAST testing has largely gone away. RAST testing stands for radioallergosorbent testing, came out in 1972, and basically it's an ELISA test. So what you have is you have a substrate and then some kind of sticky goo at the bottom, and then you, a manufacturer will create a well with one allergen, which could be cat protein or it could be peanut protein, and then what you do is you incubate it with the patient's serum. And when you do that, any IgG or any immunoglobulin the patient has that recognizes that protein as a foreign thing will bind to it. That doesn't necessarily mean that you're allergic to it. So you can actually have IgG4, which is a tolerogenic. This is something that is driven by those T regulatory cells that recognizes this stuff and is not a marker of allergy. It's actually a marker of immune tolerance. But all we care about is the IgE. And so then you have a tagging antibody. So in RAS testing, the tagging antibody was not fluorescent anti-IgE. It was radio tagged IgE with a radioisotope. And so what they actually had was a tiny little Geiger counter that would go down and sit over these wells. And again, it was originally designed to be a qualitative, not a quantitative test. It was a binary. Is it positive or is it negative? And it turns out, like skin testing, if you only use that metric, it wasn't particularly accurate. So over time, they tried to make it more accurate by figuring out, like doing these receiver operator curves with the number of rads that were emitted by these wells, but it just wasn't particularly accurate. And so there is a second generation of serologic testing looking for specific IgE, and these are the ones that use the fluorescent anti-IgE antibodies. There's 3 of them: ImmunoCap, ImmunoLite, and HiTech 288. When I did my training, I actually thought that ImmunoCap had kind of reached market dominance, but they didn't. In the real world, all of these are used, and they're all fine assays. But what ImmunoCap seems to have done was they were kind of clever. They went to academic institutions where they were doing a lot of food allergy research, and they gave them ImmunoCAP machines either for free or at a subsidized rate. So when you read research studies, the vast majority of research studies use ImmunoCAP when talking about specific IgE levels. And so if you've ever ordered one of these tests or seen one of these tests, you might see that it comes with this handy dandy graph, right? And so this is the same idea. They've done receiver operator curves, or that's the idea. And the higher, they've broken it down into classes. And the idea is, again, the higher the class, the greater the likelihood that you're truly allergic to it. So if you have a value of, say, 1, that would put you on this chart in a class 2, which would mean that you are less likely than if you had, say, a 20, which would put you into a class 4. Now, the only problem with this, I think it's well-intentioned, the problem is it's totally bogus. And the reason it's bogus is that the predictive value of these varies widely from food to food. So a 15 to milk doesn't have the same predictive value as a 15 to wheat. And so they have actually done receiver operator curves for ImmunoCAP. And because cow's milk and egg are the most common food allergies in the world, and they're the most common food allergies in children, they're actually receiver operator curves for kids over 2 years old and under 2 years old. So if you're under 2, the 95% cutoff for milk is 5. If you're over 2, it's 15. Same for egg. If you're under 2, it's 2. If you're over 2, it's 6. So peanuts about 15, tree nuts about 15, fish is about 20. So you're kind of in this 15 to 20 range. And then look at wheat. Wow. Turns out the testing for wheat is terrible. You have to have a value of greater than 100% to say with 95% certainty, yes, you're truly allergic to it. So let's say you do it and you get a value of 50 to wheat. What does that mean? I don't know. It means that you have specific IgE against wheat, but maybe you also have IgG4 against wheat, and they're imbalanced, and you have this antigen, and you can actually eat wheat with no issue. So these tests are not perfect tests, and this is where kind of clinical judgment comes in. You have to take a good history, and then you do the testing to kind of support that history, and then you have to interpret the testing and kind of work from there. The other thing you have to do if you're ever going to order serologic testing is you have to get a total IgE. And the reason for this is because a rising tide lifts all boats. So the normal range of IgE for adults is somewhere between 0 and 300 generally. So if you have a total IgE of 100 and your specific IgE to peanut is 20, I'd say there's probably a greater than 95% chance that this is a real, true food allergy. However, if you have a total IgE of 1,000 or 5,000, that's not necessarily dangerous, and there are a lot of things that can cause your IgE to be significantly elevated, the most common of which is eczema. And so this is a common pitfall. There's a baby with bad eczema, and you're trying to figure out if there could be a food contributing to it, which can be the case in about 30 to 40% of kids with eczema. And so I understand the inclination that you're going to shoot this broad panel of allergens because the baby's breastfeeding, and so maybe they're exposed to proteins through mom's milk, and so you get a specific IgE to milk and egg and wheat and soy and peanut, and they all come back elevated. And the total IgE, is 2,500. Well, what do they mean? And so those receiver operator curves and those cutoff levels are based on people with IgE levels in the normal range. And so interpretation of those numbers is always dependent on having an IgE. You have to have a total IgE. If your IgE is significantly elevated, it hampers interpretation of them. And again, this is where clinical judgment comes into contact. So that's kind of an overview of hypersensitivity and the testing modalities. In terms of the burden of disease, so food allergy, like I said, in kids about 3 to 4%, in adults about 4 to 8%. Allergic rhinitis is much more common. 30 to 40% of the population has this. It is the most common chronic disease in humans. It's responsible for about 800,000 missed days of work per year in America. Associated with daytime somnolence. If you have uncontrolled allergic rhinitis, you don't get good quality sleep. For kids, this can affect school performance. There's also an increased risk of otitis media. And then if you have allergic rhinitis, again, it puts you at risk of developing asthma down the road. Asthma for kids, 60 to 80% of kids with asthma will have an allergic contribution. For adults, it's more like 40 to 60%. So it's an interesting question. Does everybody with seasonal allergies have to see an allergist? And the answer, I would say, is no. If you're comfortable with the medications and kind of can take a good history, I don't think that everybody that has springtime allergies necessarily needs to see an allergist. The flip side is, does everybody with asthma need to see a pulmonologist? And I would say no. If you can do spirometry in the office and you're comfortable with it, that's fine. I would argue that everybody with asthma at some point in their life probably should see an allergist because, again, for kids, 60 to 80% of them, and for adults, about 50% of them will have an allergic contribution, maybe something that's avoidable or treatable, contributing to their symptoms. And then eczema, maybe 35 to 40% of kids with eczema have an allergic contribution. So how do you treat allergies? One is avoidance. You figure out what you're allergic to and you try to stay away from it. For things like dust mites and pets or foods, that's feasible. For things like pollen and mold, that's less of an option. Then medications. So for food allergy, unfortunately, antihistamines or EpiPen or epinephrine. For eczema, there are topical agents. For environmental allergies and asthma, there are a number of medications that are kind of beyond the context of this talk. One unique way that we treat allergies is immunotherapy. So classically, when we talk about immunotherapy, this is allergy shots or subcutaneous immunotherapy. So subcutaneous immunotherapy or allergy shots work. They're pretty darn effective. So 75 to 85% of patients that undergo allergy immunotherapy have reduced symptoms. They need less medications, they need fewer office visits, and generally feel better. And because of the reduction in medications and office visits, insurance companies actually pay for it because they see up to an 80% cost reduction in caring for patients with allergic disease. The number needed to treat with allergy immunotherapy to prevent a single asthma exacerbation is 2.6. I challenge you to find a medication that has a better number needed to treat. And it's safe. The reaction rate is extremely low. In national studies, it's about 1 in 10,000. In our practice, it's about 1 in 100,000 in terms of having a systemic reaction. And this is the only disease-modifying therapy. It treats the underlying cause. And the idea here is by injecting you with small amounts of the stuff that you're allergic to in a way that's not threatening to your immune system, you're actually trying to promote a population of T regulatory cells, which will then down-regulate those memory B cells to make it so that you're no longer allergic to these things. For kids with allergies, by kind of shifting that cytokine milieu and treating the allergies that you have, it prevents future sensitization. And again, you can see a cost reduction of up to 80%. The indications for allergy immunotherapy include allergic rhinoconjunctivitis, asthma, atopic dermatitis, and venom allergy. If you have a history of anaphylaxis, cutaneous systemic reaction, or a large local reaction, although only for anaphylaxis is it strongly indicated. So how does it work? Well, you have upregulation of those T regulatory cells and increased secretion of things like IL-10 and TGF-beta, and then downregulation of those Th2 cells. Why doesn't everybody do this magical miracle thing? Well, most human beings don't like to be poked with needles, and I get that. The other reason is that there is a small risk of anaphylaxis, and so you have to come into the office and have it administered in the office, and then you're observed for about half an hour, which is inconvenient. Totally get that. So there's interest in doing this in other ways, and one of them is sublingual immunotherapy. So this is a woman, this is from a website of an allergist in Louisiana, and she has this vial of stuff that's been compounded for her by her allergist, and she's squirting it under her tongue. This is the exact same stuff that we would use if we're doing subcutaneous immunotherapy. There's a couple issues with this, though. One, you're putting stuff you're allergic to in your mouth. And so people often have a sense of oral pruritus, and because of that, you can't build to a very high dose. Two, this is done on a daily basis. It is done at home. There still is a risk of anaphylaxis, and the recommendation is if you're going to do this, you have an EpiPen. Another issue with this is that for reasons that are not completely clear, it's more effective as monotherapy. So if you're only allergic to, say, cats, and you're getting cat antigen sublingually, it seems to be fairly effective. But if you add in multiple allergens like cat and grass and tree, and most people in the United States with allergies are actually polysensitized or allergic to more than one thing, it seems to lose efficacy. So it works, but it seems to generally be less effective than subcutaneous immunotherapy. And when used in this way, quote, allergy drops, the stuff that you put under your tongue, it's not FDA approved. And so because of that, it's all done out of pocket, which can be very expensive for the patient. And in our practice, we don't do that. This changed in 2014. In 2014, a sublingual tablet came out called Oral Air, which was specifically for the treatment of grass. And then within a couple of weeks, several other products came out. So there was Grass Tech and Raguatech, and these look like these are single out antigens, and they look like little lozenges, and you put them under your tongue, and they kind of have a minty taste, and it sits there and it dissolves. And again, it works, but the two limitations of this are it's monotherapy. So if you are allergic to grass, that's great. If you're allergic to ragweed, that's great. If you're allergic to cats, sorry, there's no product for that. If you're allergic to tree pollen, nope, no product for that either, or dust mites. And again, you're back to taking a medicine every day, which people generally don't like. Unfortunately for food allergy, there is no immunotherapy right now. They looked at this in the 1990s, and they were doing a double-blind placebo-controlled trial at the University of North Carolina, very prestigious and good institution. And what happened is there was a pharmacy error. So they were doing injected immunotherapy to peanut, and there was a pharmacy error. And what a double-blind placebo-controlled trial means is that neither the patients or the doctors administering the stuff know what the patients are actually getting. And so a syringe of full peanut allergen was labeled as placebo, and somebody in the placebo group got it, and they died. So they stopped the study and they published it, and it's kind of become the third rail of the allergy world, and no one has touched injected immunotherapy food since the 1990s. It's not surprising to me that that hasn't happened in the United States, because we kind of are litigious, we like to sue people, and the FDA is very strict. It's more interesting to me that no one in the world has touched it. So no one in Europe or Australia or Japan or China or South America has touched injected immunotherapy. So in the last few years, there's been a strong interest in other ways to do this, including sublingual immunotherapy or oral immunotherapy. And in fact, right now, they're in phase 3 trials for a peanut patch, an epicutaneous patch, which is like a nicotine patch, but it contains small amounts of peanut protein. I think that's probably going to be the first to come to market because it has the best safety profile, but unfortunately, it's also the least efficacious. So the jury is still kind of out on that. So just to kind of review, we've talked about the 4 types of hypersensitivity reactions, which are really inappropriate. They're not hyper. They're just recognizing things that are not dangerous as a foreign thing. Allergic disease is fairly prevalent in the pediatric population, but also in adults. And then allergy testing, when you're going to get it, always needs to be supported by history. And that's the end. I hope you enjoyed this talk.